We'll be talking in brief about viral hepatitis in pregnancy. The brief outline of the presentation will be what are the main types of viral hepatitis in pregnancy, what are their clinical presentation, what's the magnitude of the problem, what are the risks associated with viral hepatitis to the pregnant woman, to the fetus, infant, and the preventive measures, and the specific issue of hepatitis B positive pregnant women. The main types of viral hepatitis which are seen during the pregnancies are commonly you must have seen hepatitis A, E, herpes simplex, hepatitis B, and hepatitis C. They have varied clinical presentation, which can vary from acute viral hepatitis to fulminant hepatic failure or incidental detection of hepatitis B or C during the prenatal checkup or the ANC checkup. Hepatitis A, E, B, and herpes simplex has been associated with acute viral hepatitis and fulminant hepatic failure. This was a study which was published in Annals of Internal Medicine, which had 33,385 pregnant females who were admitted to Lady Hardinge Medical College from Jan 2003 to July 2005. And of which 316 patients presented with jaundice, that is 0.1%, of which the most common cause was acute viral hepatitis, which was responsible for almost 3/4 of the cases, that is 70% of the cases, 220 of 316 cases. And the rest will be intrahepatic cholestasis of pregnancy, HELLP syndrome, acute fatty liver of pregnancy, drug-induced hepatotoxicity, hemolytic anemia, choledocholithiasis, dual viral infection, and unknown cause. Of the 220 patients who presented with acute viral hepatitis, the three common viruses which were responsible were hepatitis A, E, and hepatitis B, of which hepatitis E was the commonest, accounting for 60% of the cases, followed by hepatitis B, which accounted for 1/3 of the cases, and 7% were because of hepatitis A. Viral hepatitis was diagnosed when the serum bilirubin was more than 2 mg per deciliter and ALT value more than 2.5 of upper limit of normal. And the serological marker that are commonly done were hepatitis B, C, hepatitis A, IgM, and IgM hepatitis E. Of this spectrum of the acute viral hepatitis, 91 of the 220 patients, that is 40% of the patient, had fulminant hepatic failure, of which at the time of presentation, 60% of the patient had hepatic failure, and during hospitalization, 40% had fulminant hepatic failure. This basically shows that the acute hepatitis C has the predisposition to have acute viral hepatitis complicating with fulminant hepatic failure, that is accounting for 55% of the cases. The fulminant hepatic failure, which was seen in 91 patients, of which 50% of the patient manifested in third trimester and 61% manifested in the second trimester in the hepatitis A patient. Those patients who presented with hepatitis C induced fulminant hepatic failure, they usually had a very high mortality, which ranged up to 70%, and was significant as compared to the patient who had non-hepatitis C related fulminant hepatic failure. Coming on to the prevalence of hepatitis B in pregnancy, there's a variant study which have been done in India at multiple centers, which showed the overall prevalence of hepatitis B among the Indian pregnant female is approximately 1%. So what are the risks of viral hepatitis to pregnant women? It depends upon the type of viral hepatitis. The hepatitis A is usually associated with gestational complications, preterm labor, and the timing of at which the virus is at highest risk is second half of pregnancy, especially the third trimester. Hepatitis B is associated. Flares of chronic hepatitis B can occur during the pregnancy or the postpartum period. Hepatitis C is usually not commonly seen or associated with potential risk to the mother or the child. Hepatitis C has been associated with eclampsia, acute liver failure, and is commonly seen in second and third trimester. HSV hepatitis is associated with acute liver failure seen during the third trimester. What are the risks of viral hepatitis to the fetus and preventive measures? For hepatitis A, there is no evidence that hepatitis A causes a birth defect. Fetal ascites, meconium peritonitis can be seen, but they're very rare, mainly if the mother is infected during the first trimester. There is no evidence of maternal to fetal transmission in rare circumstances in which the mother has acute hepatitis A infection at the time of delivery. If serum immunoglobulin can be administered to the infant, there is no transmission of the anti-HIV IgG antibodies from the infected mother to the newborn infant. For hepatitis B, spontaneous abortion, premature delivery risk is higher when the mother is infected in third trimester. Transmission usually occurs in intrapartum or the peripartum throughout the close contact with the mother and the neonate. Significant vertical transmission is known in patient who is HIV RNA positive, in patient who have symptomatic infection that they manifest jaundice or fulminant hepatic failure or acute viral hepatitis. The transmission to the fetus reaches up to 100%, which is associated with significant perinatal mortality and morbidity. For hepatitis C, the rate of vertical transmission is up less than 5%, and the risk is highest when the mother is co-infected with retrovirus HIV or she is viremic at the time of delivery. Load is greater than 1 million copies per ml if the time from the rupture of membrane to the delivery is more than 6 hours. For HSV, the risk of vertical transmission, the primary infection at the time of delivery is up to seen in 40 to 44%. First time episode of genital non-primary infection, 24 to 31%. Recurrent infection, it can be seen into 1.3 to 3%. Intrauterine infection is rare, and 85% of the infection are usually in the perinatal period and 10% in the postnatal. Invasive fetal monitoring, prolonged rupture of membrane, and vaginal delivery increases risk of vertical transmission. So treat the mother with the primary or the first episode of genital HSV infection with acyclovir. Consider suppressive therapy for recurrent infection at 36 weeks of pregnancy. Consider cesarean section delivery if the predicted risk of transmission is high. So coming on to the hepatitis B, these are the key issues which basically shows the effect of hepatitis B on the pregnancy and the fetus, changes in the course of hepatitis B infection during the pregnancy, precautions to reduce the risk of transmission from the mother to the child, and treatment of chronic hepatitis B in pregnant women. So coming on to the effect of hepatitis B on pregnancy outcome, acute hepatitis B is usually not associated with increased maternal mortality or teratogenic effect. There's a higher incidence of low birth weight and prematurity that have been reported. Chronic hepatitis B infection is usually associated with higher risk of gestational diabetes mellitus, higher risk of prematurity, low birth weight, and however, it's not associated with preeclampsia. And the outcome can be worse if the patient is having underlying cirrhosis. So there's no worsening of the liver disease, which is seen in the common in majority of the patient with hepatitis B during pregnancy. The liver enzyme frequently normalize. Pregnancy basically suppresses the immunity. That is, there is more of Th2 cell more than Th1 cell, and in postpartum Th1 exceeds the Th2. So postpartum flare can be noted in up to 10 to 30%, especially in anti-E positive hepatitis B. However, it is usually asymptomatic and resolves spontaneously. Rarely, it can cause decompensation of underlying compensated chronic liver disease. So these are the possible route of transmission of hepatitis B from mother to the child, which can be prenatal, natal, and postnatal. Commonly, it is natal, which accounts for 60 to 80% of the transmission of the maternal fetal hepatitis B. It is secondary to the micro transfusion during the delivery, threatened preterm labor instrumentation and placental leakage increases the risk of transmission and swallowing of infected fluid from the mother to the child. Intrauterine infection accounts for 13 to 40% of the infection. They can be secondary to the minor laceration of placenta, threatened abortion, threatened preterm labor, torch infection, placental infection by hepatitis B, infection of peripheral blood, leukocyte, oocyte, or sperm infection, or sending infection. Postnatal, which accounts for 5 to 10% of the cases, can be secondary to the intimate contact or exposure to the maternal fluid of milk. This basically shows that without prophylaxis, with E positive and anti-negative, 70 to 90% transmit, and with 25% in E negative and anti-negative, and anti-positive, 12% risk of transmission. And the risk of chronicity is highest in the neonates, which gradually decreases over as from infant children to adult. So the prevention of perinatal hepatitis B transmission is cornerstone is basically hepatitis B immunoglobulin plus hepatitis B vaccine combination, and its efficacy is up to 95%. So it is usually administered within the 12 hours of birth at the different site. The reason for failure can be failure to complete the vaccine series. Mother is having high DNA or anti-HBe positive, HBe positive, and there can be delay in administration of immunoglobulin or the first dose of the vaccine. So the risk of transmission is higher when the DNA is detectable as compared to the non-detectable DNA. So it is a risk factor for the transmission from the infant to the child. This basically shows the vertical transmission of the hepatitis B, and E negative and a viral load less than log 7 usually identifies the women who are at extremely low risk of transmission after the immunoprophylaxis and who are unlikely to benefit from the other intervention. This basically shows the paired 302 mother-infant pair, of which 26% with of HBe positive, which basically shows as the maternal viral load increases, there is a risk in the transmission of the hepatitis B rate in the children. So these are the clinical scenarios which we can see commonly in hepatitis B in pregnancy. Pregnant woman is detected to have hepatitis B during the routine antenatal checkup or anytime during the pregnancy without symptoms or jaundice. Woman with hepatitis B infection with or without liver disease contemplates pregnancy and seeks your opinion. Hepatitis B woman on antiviral which wants to plan pregnancy or gets pregnant, or hepatitis B is detected during the postpartum period. So these are the issues which we commonly encounter with the pregnant female with hepatitis B and her baby. Should antiviral should be recommended to all the patients with liver disease with hepatitis B? Should antiviral be recommended to reduce the risk of perinatal transmission? What should be the cutoff of maternal DNA level for initiation of antiviral, and when to start? Which antiviral to be given, when to stop, and what is the risk of post-treatment flares? So other issue is the role of cesarean section and the breastfeeding of the baby. So to conclude, viral hepatitis should be considered in pregnant women presenting with abnormal LFTs or acute hepatic illness or fulminant hepatic failure. The most common cause of jaundice is acute viral hepatitis in a pregnant female. Hepatitis is the most common cause of viral hepatitis and fulminant hepatic failure, and hepatitis C high mortality is noted with fulminant hepatic failure. Thank you. So to conclude, some viruses have risk of transmission from mother to infant. Hepatitis C, when HIV RNA is positive. Hepatitis C, if the mother is HIV positive. Hepatitis B, if no immune prophylaxis is given, and HSV. Hepatitis B infection poses specific issues in pregnant women. Thank you.